Hello. So today we are lucky to have Saloni Dattani with us. She writes on Substack at Scientific Discovery and is a researcher on global health at Our World in Data, where she focuses on global health related topics, including things like mental health, and also a founding editor of Works in Progress. And she will be hosted by Berke Celik. Berke works as the lead of the development program and founding director of the Health Progress Hub initiative at the Global Policy Research Group. He's passionate about global health, R&D policy, economic growth, and strengthening health systems. And he has also worked with the Lead Exposure Elimination Project for their Turkey project. Thank you both for being here with us, and I'm looking forward to the conversation.
Same here. Yeah, thank you for having me.
Yep. Thank you for the introductions, Dominic. And once again, thanks, Saloni, for taking the time to join this event. We can directly start with your work. What drew you to focus on the areas that you're focusing on, particularly when it comes to the work you're doing at Our World in Data? What drew you to focus on those areas? Were you interested in those areas when you were studying, or did those interests emerge once you started your professional career?
I think it's a mix of different reasons. So I cover quite a lot of topics from infectious diseases to cardiovascular disease, medical innovation, just data quality, vaccines and all of demography as well. So I think it's a bunch of different reasons. I think with some of them, it's areas that I'm quite familiar with um, from my research before I joined Our World in Data. Often research methods and data quality in particular was one area that I focused a lot in my PhD. And then infectious diseases, I think there it's a topic where there's so much that we can do and there's so much progress that's already been made in the field. And I think it's a good topic to introduce people to how much health and healthcare matters in the real world. And then there's other topics, I think, like demography, looking at things like life expectancy or causes of death and how those change over time. And I tend to like those because they show you this broad picture, like snapshots, but also, how things have changed and how that's influenced by both medical innovation, healthcare policy, economic policy, so on. And like I think it's just a great way to kind of put the topic in context.
Thanks. To double down on that, how would you describe the exact work you're doing at Our World in Data in terms of like how does your average day go as a researcher at Our World in Data, and how do you think you're producing impact, or how do you think Our World in Data is contributing to progress on these important issues?
I think a lot of it is communicating the science. So, well, I guess it's several things. One is communicating the science that researchers know about, but the public is less aware of. So, for example, I recently wrote an article about HPV vaccines and how they can help eliminate cervical cancer. There are a lot of people who don't really know very much about that topic at all, even though it's very well established in the literature. So I think one thing that I work on is just trying to communicate things in a easy to understand and clear way. Um, the other is kind of helping researchers and journalists make sense of the data on a topic. So that might be trying to explain what life expectancy actually means, how to interpret it, what it means when life expectancy suddenly drops, and so on. And then I think another is kind of highlighting areas that we need to make more progress on, or highlighting things that we should be doing. Um, and then I think that's sort of a mixture of trying to understand the policy impacts of some idea, or trying to find like a gap in like what's not being done currently, whether that's like we haven't collected data on this topic, or we have this technology but no one's using it enough, or here's an idea like advanced market commitments that could help encourage innovation in this area and help spread some innovation in countries that need it.
In terms of collecting data about mortality and disease burden about various medical conditions, what are the main challenges in collecting that, rather than the perspective of a researcher that's trying to access that data when it comes to the ground? It seems like many countries don't have that much capacity to collect data. Why is that the case? What are the main constraints and challenges there?
Yeah, I mean, I think if you think about the sort of step-by-step process of how this would happen, so someone might die, they might be in a city center or they might be in a rural town. After that happens, they have to have a death certificate filled in. Often that's enforced by the government, but it still might not happen. Maybe they don't live close enough to hospitals or authorities where someone will fill in that sort of certificate. Maybe the doctor, or maybe someone will fill in the death certificate, but they don't know enough information about the person. There aren't records of their birth certificates, there aren't their medical records or testing, so they don't know what the cause of death was. Um, that's often the case outside, when people die outside of hospitals, especially in rural areas. And that's one big reason that we don't have a lot of this recording. And then obviously there are also these like institutional factors. Like, does the country actually have the administration to collect all of these death certificates, store them, and analyze them every year? And for very poor regions, that can often be quite difficult. So in a lot of African countries and South Asian countries, in particular, we have very limited data on specific causes of deaths for often a large share of the population, because of these kinds of reasons. So a lack of doctors, people dying in rural areas without medical records, a lack of institutions to record these causes of death, and so on. And what that means is that we just have a lot of uncertainty about what people are dying from. And that can seem very surprising, often, especially because the stuff that I write about is often, what are people dying from in poor countries? What can we do to reduce these preventable causes of death? And instead, the reason that we can say this, at least with a little bit of confidence, is that we have these um, surveys that are often done in poor countries. So these surveys are called verbal autopsies. And instead of having a death certificate filled in for each person, you'd have a group of people doing a survey where they would go to each household, talk to the relatives of the person who has died, and ask them what symptoms did they have before their death, what diseases did they have, what medicines were they taking, and so on. And based on the answers to those questions, a doctor will try to guess the cause of death. He'll often be several doctors looking at the same answers and trying to determine that cause, and then they'll try to come to a conclusion. And based on that, we might have the survey carried out at a national level or in some regions, and then we try to estimate how those causes of death vary across that country or across that region. So I think we do have a fair idea of some of these causes of death, but there's also a lot that we're missing. Often these surveys are not carried out very regularly. They might be, once every 10 years or something, or there might just be in certain regions within a continent, and you aren't necessarily getting the full picture. And then secondly, we don't have a great understanding of like the trends over time. Those are kind of extrapolated from various other data that we have, but it can still be difficult and come with uncertainties.
When it comes to the limiting factor of like conduct, or I think it's better to put it this way. So let's say you're talking to a grant maker or you're talking to someone influential and they're just curious about the problem. Cause of death data is tends to be low quality or just doesn't exist in many LMICs. Is more verbal autopsies the answer there? Are there any interventions or particular policies that would provide a more fundamental solution to this problem compared to verbal autopsies conducted by researchers or the government?
Yeah, great question. So I think I mean, I think it's a mix of both. Like if we go back to that sort of process of how death is recorded and what the cause of death is, I mean, you can try to, increase the number of doctors and nurses in the area. You could improve medical testing or hospital capacity, invest in hospitals in these places as well. And I think those are important in the long term. In the short term, though, like it's going to take a long time to build up that capacity. But also, I think one reason that I think these surveys are quite useful is partly because they're very cheap. So in India, for example, they conducted this national survey, as I described, between 2000, the year two, I think it was 2000 and 2014. And they did it every 6 months. They talked to a few million households, and it cost about $1 per household. So it was very cheap in terms of what it was able to identify and the scale of the study that was conducted. So I think in that sense, I would actually encourage people to fund surveys instead of thinking about healthcare capacity as a way to solve this problem. Those are obviously important also for other reasons, but they're much more expensive and hard to scale up.
Are there any particular countries that have improved their capacity to collect this cause of death data, particularly in like resource constraint contexts? Can you think of any examples again? It
Hmm.
doesn't have to be a country, maybe a municipality, or like any polity that has done a good job of addressing this issue with by increasing their administrative capacity rather than verbal autopsy.
So I think India has been able to do that, especially in various South Indian states. The problem is that even though they have built up the capacity, there are still a lot of people who die outside of hospitals, which makes it still quite hard to collect the data for them. So I think I would probably give that as the example. There have been these surveys conducted in various regions of, West and Central Africa as well. So, these things are ongoing, but they haven't really been scaled up yet.
I think like an example that further illustrates the importance of this issue is snake bites. And I know that you've written about this issue. Would you like to talk a bit about snake bites and how the Indian government and the World Health Organization underestimated the burden and mortality from snake bites and how the problem was actually much bigger than they thought?
Sure. Yeah. I mean, snake bites are, I think, a very clear example of how much this can make a difference. So, until about 10 years ago, most of the global estimates of, how many people died from snake bites were, in the tens of thousands. And it really wasn't clear that it was a big problem. And one of the reasons for this was that the people who were disproportionately dying from snake bites were the people in the most rural areas, often poor farmers who might be bitten by a snake during their occupational work. They would live very far from hospitals, so they would be less likely to receive antivenom, but also less likely to have their death recorded and to have their cause of death recorded. So in India, across the whole of India, there had only been around 1 or 2 thousand deaths from snake bites recorded per year between 2000 and 2014. And they sort of had this impression that like maybe this problem is underestimated. So some researchers had tried to use other methods as well. The Indian government set up this compensation scheme so that if you had been bitten by a snake or your family had been, then you could receive some compensation. And by looking at data like that, the estimates had been revised upwards. So maybe it was 10,000 deaths, not 1,000 or 2,000. And even that would still have problems. There might just not be the ability of the family members to access this compensation or to even know that it existed and so on. And so when this survey was conducted, they estimated instead that across India, the burden was about 50,000 deaths per year. That was much higher than anyone had imagined. It was, about more than 50 times what the official death count was. It was also 10 times, 5 times the other estimate from these compensation schemes. And so it was quite a shocking result, I think, to the health community. And it meant that the WHO then sort of revised their estimates of the global burden of snake bites. So there have also been some other surveys in different parts of Africa looking at this and also finding, significant burden of snake bite. And so now the global estimate is about 100,000 deaths per year, which is much higher than it was before.
I actually want to continue discussing the importance of why this issue is particularly important, but I had another question relating to the history of data collection capabilities of European governments and American governments.
Mhm.
Do you know how these capabilities emerged or was improved in more high income country context over the years? Like, um, is there a particular century or a period where these governments were able to improve their capacity to collect this data, or were they always ahead in terms of basically administrative capacity to do these things compared to LMICs? Like, what is the history of this thing in US or in Europe?
Yeah, it's a great question. One of the big stimulations for doing this kind of research and data collection was actually the spread of epidemics. So countries would want to track epidemics to understand, when there was a new wave emerging, where it was emerging, and so on. What were the infectious causes of death in a particular year? And I think some of the first, versions of this were actually conducted in cities. So the city of London, I think, had started collecting data on causes of death in the 17th century. But it was only instituted across England some 200 years later. And so it's sort of you often see this pattern where there are cities that start collecting this data, the cities that have institutional capacity, and then as the state level administrative capacity grows, they try to bring that to the national level. So one of the big reasons was outbreaks of bubonic plague, cholera as well. Like as you might know, there's this very famous story about John Snow collecting data on cholera cases across London to try to track down where the outbreak had began, and he managed to trace it to a contaminated water pump. So things like that helped people at the time to figure out where these outbreaks were emerging from, what the, most effective thing to do would be, and then also to track their changes over time. And it was mostly initiated for infectious diseases.
Okay, thank you very much for that. And yeah, the other question, I'll now ask a more specific question. So again, it seems like verbal autopsies work better for understanding um, certain causes of death compared to others. For example, if it's a really complex medical condition, then it seems like verbal autopsies are worse placed to identify that. So, is there a subset of medical conditions where not only government cause of death data is somewhat unreliable, but also these verbal autopsies are unreliable? And like related to this question, I want to ask this like more broad question. So you have the snake bites example from India. Um, and what are some issues where humanity as a whole may be underestimating the burden from that particular disease? And again, like this may be related to some recent paper you read, or it may be a prediction you're making. Like, for example, in retrospect, 5 years later, uh, what are we going to look back at and say, oh, how did we underestimate that at that level?
Yeah, great question. So I think there are several sort of things that or categories of causes of death that I would think are underestimated or misestimated in some way. One of the big ones is cardiovascular diseases. So and cancer. So the problem with them is that you often don't know exactly where the cancer might have started, especially if it's something that turned into a metastatic disease. And trying to test for cancers or specific cardiovascular diseases that can be quite difficult in poor areas. And you would just have, instead of a specific cause, people would just write things like chest pain or um, sweating or fevers, and they wouldn't have a clear understanding of what the cause was. And so you would get these vague terms on death certificates instead. So I think that's one area where I don't think we would be underestimating them, but we're just not clear about what the specific causes are within those categories. The causes of death, which I would guess would be underestimated, are also other things that affect people in rural areas who are not counted by these existing death registers. So it would be things that are disproportionately likely to affect them. And so my sort of vague guess at this would be sort of some occupational hazards, maybe some fire accidents, electrical accidents, things like that. One other example that we now know has a much bigger burden than we thought before is drowning. So just children drowning in floods or rivers, and so on. Um, so I think it's often going to be things like that. And then the other reason that we find it very difficult in some cases is with infectious diseases, especially with infectious diseases where the symptoms are not very specific. So there are so many different causes of having a fever, for example, or having a diarrheal disease. And just having this broad category is not very informative for what you should be doing about it. And so I would guess that that's an area where I think we'd probably be misestimating the specific causes of death within those categories.
A related question I want to ask, and again, this is a quite specific question. So, um, like, was one of the reasons why lead exposure was so neglected up until a few weeks ago, does that have to do with the quality of the data that was available? Because, for context, for people who may watch this, um, lead exposure is an indirect cause of death, and it's also a risk factor for a bunch of stuff, so it's really hard to estimate, I think. So is that one of the reasons why lead exposure was neglected, or was there already this literature demonstrating why lead exposure is an important thing, and the inaction on that was just primarily due to lack of interest from policymakers and funders? Um,
Yeah, so this is it's difficult because so in the late 20th century there was a lot of research conducted on the toxic exposure effects of lead in lead pipes and contaminated water and so on. And one of the main effects that it has is kind of affecting brain development. So lead is a very small molecule that can fit into what your brain usually uses for calcium receptors. And that means that it just sort of blocks the ability of your brain to transmit uh, information properly in various regards. And so we had understood that lead was a problem. I think that the difficulty was trying to understand how much of a problem it was, like what and other outcomes it affected. So one, I think, very, uh, one consensus view is that it affects sort of behavior, especially like attitude or criminal behavior and violence. But it could also affect IQ and, various other, functioning capacities. And so I think there's that problem, but there's also this problem of not actually knowing how much lead is present in the environment and what people are being exposed to. So we can do this research on, lead in pipes, but then people might also be exposed to lead through, spices or through toys or, other, things that they have at home. And so the way that you would try to estimate how much exposure people had would be through blood tests, not just through trying to measure individual objects. And that's quite expensive to do. It's definitely not expensive relative to the benefits of studying the problem, but it's quite difficult. It has been quite difficult for people to study it in poorer countries so far. So recently there have been various initiatives to, try to measure how much lead content there is in household spices like turmeric or in paint or in toys that children use. But that I think that has been quite recent. And then the other problem is that we don't have great national surveys yet for lead content in children's blood, except in a few regions. So we don't really have a great understanding of the global prevalence of this problem, even though in the places that it has been studied, it has been quite common.
And again, for context, I think the total number of low and middle income countries that have run nationally representative blood lead level surveys is something like four or five. It's surprisingly low. So, yeah, about death data, mortality data, and cause of death data. These were my questions. One final question I can ask, and again, you may also use this question to make any final points relating to this
Mhm.
issue. Um, I mean, you have already answered this question throughout your answers, but should this be a priority for global health and development research community? The answer to that seems kind of clear, but again, I want to give you another opportunity to emphasize whatever you'd like to emphasize. And related to that, is this issue particularly important for the pockets of global health and development research community that particularly cares about prioritization? Um, yeah.
Yeah, no, it's a great question. So I think that I mean I think it should be a priority. I think first it is relatively cheap relative to the benefits. We do actually want to be able to track, how much progress are we making? Are there new problems emerging and so on, but also we could be misestimating some of these things by a very large factor. I think snake bite is probably an extreme example where we were underestimating it by almost 50 times in some countries. But with even other conditions, what if there are some diseases that are easy to prevent and we just don't know that those affect so many people? Or, what if we're spending a lot of resources on diseases that are not that common in certain areas. And, we should be able to collect this data to be able to know not just what to prioritize, but where those resources are needed, how many resources are needed, and so on. So I think it's really valuable for that reason. A lot of other global health initiatives depend on estimates of these issues. So I think it's kind of this underlying problem that would affect all of these later decisions. One of the other things that reminded me of though was there are obviously various limitations of doing this. I think it would be really helpful for certain diseases or conditions that are quite easy for relatives to remember or be able to describe, and we would get a good overall picture of the types of causes of deaths that are common, especially for things that are easy to determine, but also for kind of broad categories. But there are various areas where it would not be very helpful. So it would be probably most helpful for kind of understanding sudden deaths where the cause is often quite clear. So it might be an accident or it might be a snake bite or things that you can clearly attribute the cause to the death. With other things that are less specific, it's much less helpful, and I think other methods would probably help more. But this would be a good way to have, a basic picture of what's going on. And then there are also other examples. One area where I think it would be not very helpful is trying to understand different types of accidents and homicides, especially. So, as you can imagine, trying to ask relatives, what was the cause of death of your husband or your father or so on. And if it was a suicide or a homicide, people are obviously much more sensitive to sharing that information with, if someone who's unfamiliar and is a survey researcher. They don't know what they're going to do with that information. And so I think with things like that, where the cause of death is quite sensitive, we might be underestimating their burden.
By the way, related to your final point, it also seems like, I mean, your point also kind of constitutes a counterpoint to what I'm going to say, but it seems like verbal autopsies also provide some clues regarding crime data, because my guess would be in many countries where you don't have high quality cause of death data, you
Mhm.
also have certain issues. You are also likely to find some issues with collecting crime data. But again, due to the reasons you said, probably crime data would be underreported, or like crime related data would be underreported
Right.
in those autopsies. So before talking more about global health R&D, I want to ask a question not about data collection, but how it's leveraged. So again, you've been talking about these data collection constraints and how it could be improved. When it comes to leveraging data that's already collected by, I don't know, community health workers or um, basically local health services in developing countries. Are there any low-hanging fruits or interventions that could be valuable when it comes to aggregating or leveraging that data? Because my guess would be it's kind of a bureaucracy in a developing country. There would be a lot of inefficiency going on. I wouldn't be surprised if there isn't that much digitization and it's not that well, it's not sent to some central authority that could make use of that data. Yeah, when it comes to leveraging collecting data, are there any big issues, and are there any low-hanging fruits?
Yeah, again, great question. I think I mean it's interesting because I have just been writing about our world in data's work during COVID, putting together these global data sets of, testing rates and vaccination rates, but then also putting together other data sets from other organizations. And I think there are a lot of similar issues regardless of what the type of data is. You'll have you will often not have a kind of single place to collect or to identify all of this data. People will, they might have some centralized online resource, but then it isn't updated regularly, or it doesn't collect, it doesn't contain the information across different diseases, and so on, or it's in this very messy format in like PDF reports or Word documents or things like that. Um, I think a lot of that is going to be sort of technological capacity, and especially now, probably just using some kind of things to just move the paper records into an online repository. And often the things that people can do that would be really helpful are just providing a spreadsheet or something like that with another organization that is better placed to put all of that together across countries. So kind of, doing the basics, putting together the actual numbers, and then sharing that in a very publicly accessible and documented way. I think those are the two main things I would recommend.
Okay. Thank you very much. Um, Actually, Dominic has written me something that pushes me to ask another question.
Sure.
So you have certain things. That may not kill that many people, or yeah, there are certain things where the indirect effects are great. For example, air pollution or water quality, and another example would be, I just thought of another example, but I can't exactly, antimicrobial resistance. For example, I think antimicrobial
Mhm.
resistance associated mortality is much, much greater compared to deaths that are directly attributable to antimicrobial resistance. A question about that is, when doctors or like researchers are evaluating these verbal autopsies, do they also think about risk factors, or do these verbal autopsy studies provide valuable clues to people who would like to estimate the importance and scale of these indirect risk factors?
Hmm. I haven't actually seen that happen yet. I mean, I think they would be in principle. I think they just haven't been used for that. So, but one thing that's important to mention is that regardless of whether the data comes from a verbal autopsy survey or from a doctor filling in a death certificate, they still have to use their, personal judgments to try to guess what the cause of death is. They're still limited in the information that they have in both cases. A doctor in a hospital might not have access to the medical records, or they might have only a little bit of information from the relatives, and not know very much about the person's medical history. And so, in both cases, they're quite limited and often trying to guess based on things like risk factors, the common conditions that they see in the hospital, and the sort of relationships between these things.
Thank you very much for that. And now I'm going to switch to some questions about global health R&D. So, um, I've seen that you worked on, or you thought on global health R&D, particularly your episode on Hear This Idea. Related to that, I want to ask, like, um, is there a positive trend when it comes to global health R&D? And again, it's a very broad question because global health R&D is a very large thing. So if you'd like, you can also address a specific subset of global health R&D that you're particularly knowledgeable about. But yeah, it seems like globally we are underinvesting in global health R&D. But is there a positive trend on that when we look at recent years, or is there a negative trend? Basically, how is it going?
Mhm. Yeah, so it varies between different areas. So, one example where we've seen less R&D funding is antibiotics. So, antibiotics had a lot of funding in the 1950s and 60s, especially. And since then, the amount of funding that's been put into that area has kind of gradually been declining. There are a few different reasons for that. One was that the 50s and 60s were this big period of kind of military, like a war funding efforts for trying to develop antibiotics, mostly for military purposes, so to protect soldiers in World War II, but also in other regions. And then um, there were various efforts to kind of coordinate researchers to work on this field and develop new antibiotics. And we managed to pick a lot of the low-hanging fruit quite quickly. And there are a lot of antibiotics developed in that time. And then pharmaceutical companies after that sort of lost interest for a bunch of reasons. One was the quick development of antibiotic resistance to each of these drugs. So you would not have a very long, like you would not have a huge market after you developed an antibiotic, or the conditions that it was useful for treating slowly became resistant to it. So there wasn't like a stable market. The second was that they're very short-term drugs. They're not chronic treatments that have a much, higher usage. And then the final reason was we had sort of identified some organisms that often produced a lot of antibiotics naturally, and tried to synthesize them from those particular organisms. And then we haven't really looked very much further since then. So a lot of pharmaceutical companies have tried to kind of screen a lot of their existing drug libraries. So they'll have like thousands of compounds that they've already tested and they have stored in their labs, and they'll test those for potential antibiotic effects. And so we've kind of rescreened a lot of the same compounds again and again, and sort of just found the same antibiotics again and again. And we haven't looked that much further in terms of other bacterial species or fungi that produce antibiotics. And people have sort of lost interest, I think, for part of that, for those reasons. So I think that's an area where there's a lot of low-hanging fruit still. So if we do decide that this is an area that we want to develop new antibiotic drugs, trying to look for other organisms that could produce antibiotics, or just incentivizing pharmaceutical companies in some other way to develop a market for this product before it exists, I think is a great thing to work on. And then there are other areas where I think the trend is a bit more positive. So vaccines especially had this huge boost in R&D funding during COVID, but also that has, been much above the funding level now. It's still much higher than it was before. I think we don't really know how that's going to change now with the U.S. Election outcome. I think because a lot of the R&D funding comes from the U.S. And so there could be a lot of other impacts that has on health R&D more broadly.
Um, I have the last thing you said is very interesting to me, but before that, I want to ask two questions about antibiotics. The first one is again really specific. So I actually haven't heard about the the fact that military was one of the reasons, or like interest of the military was one of the reasons why so many antibiotics were developed in the 50s and 60s. First question, do you know whether like um, public R&D expenditure for new antibiotics went down after the 60s? And like how was the economic production of like what were the incentives back then? Was it like government contracts, or was it more related to the things you said? Like once you're able to oversell antibiotics without thinking about resistance, it's automatically more profitable. But is there a more public or like government contract or like government incentive sort of thing going on there? And secondly, yeah, you can answer that first, and I can ask that second.
Sure. Yeah. So I think many people will know of, for example, penicillin and maybe some sulfa drugs, which are some examples of antibiotics that were developed in the 1920s and 30s. But it took quite a long time to mass manufacture them. So we had identified these potential antibiotics, and we just didn't really know how to scale them up, or what was the productive source of penicillin? Like which fungi can we um, uh, produce these very prolifically? And so in the US, I think it was the UK which first had this idea. They had first identified penicillin, but also had realized that it was a very important potential new treatment for infections that would occur in wounds of soldiers during the war. And they contacted the US, specifically this scientist called Vannevar Bush. He ran the Office for Scientific Research Development. I think that's what it's called, which was this small organization just below the sort of presidential authority that decided where to coordinate research funding in the US. So they often would develop contracts with private organizations or with academic researchers to work on specific areas where they thought that there was a lot of both sort of public importance, but also national security importance, such as antibiotics. But they also actually helped coordinate these collaborative, sort of these efforts between public academic scientists, military researchers, and then various industries like the agricultural industry or whatever. So we would have these efforts to both bring those different groups together, share the data between them on antibiotics that were being produced. They would often have these sort of conferences, or like they would have run-throughs where someone would actually show the other scientists how they had produced these antibiotics step by step. And that's obviously not something that you would see usually in the pharmaceutical industry. There's this huge importance played on trade secrets, and you wouldn't want necessarily for other companies to know exactly what your processes. But in this case, they decided this was of national importance to try to mass manufacture these drugs. So that was a huge, efforts during World War II that also involved a lot of funding. And since then, I don't know what the actual numbers are, and I've been trying to find those, but it has declined since then. And even in the last 20 years, the amount of funding for antibiotic research has declined.
Um, Thank you very much for that. Related to global health R&D and also related to antibiotics specifically, what I want to ask is, global health R&D is very obviously important. Better drugs are just better. What I want to ask is, for example, when it comes to antibiotics, some of the existing antibiotics just aren't available in countries where there's significant unmet need, and they would very much benefit from the from availability of those antibiotics. So what I want to ask is, um, so when it global health R&D is neglected depending on which subset of it is one is looking at. But do you think whether the following type of projects or research is somewhat undersupplied? Basically, thinking about how the end products of those global health R&D efforts will be diffused in low-income countries. Because again, a very concrete example is antibiotics, and my guess is this would be the
Mhm.
case for many other technologies. And again, uh, probably the end products of these global health R&D processes will probably be more expensive compared to drugs that we've discovered much, much longer ago. How to think about that problem, and is it indeed something that's very neglected, yet something that's very important?
I think it depends on the area. So there are some areas where we do have big on the ground efforts to kind of distribute these across countries. So some antibiotics have already been given out through that. So in the early 2010s, there was this project to work on trachoma, which is this bacterial infection of the eye that can sometimes lead to blindness. And it's very easy to treat with antibiotics if you're able to capture it soon, but you can also just give it out en masse to people at need. And the a bunch of organizations came together to run this mapping project where they had healthcare workers and researchers just go out to households, try to actually diagnose whether they had these eye infections. And using that, they estimated the prevalence of trachoma in different districts and countries. Based on that, they then decided how much of these antibiotics to provide to people across the country. And the World Health Organization, I think, recommended some like between 1 dose of these antibiotics per year to 10, depending on how common the condition was. And they actually kind of rolled it out quite substantially across the country. There's, I think, some hundreds of millions of people who have received these antibiotics through these efforts, mostly children. And it's it's been quite effective at, reducing the prevalence of trachoma, but what was, I think, surprising to some people was also how much of an impact it had on other health outcomes. So there have been some studies looking at that data afterwards and finding in randomized control trials and across the country, you would find declines of about 15% in child mortality. So just giving out these antibiotics once or twice a year reduced child mortality by about 15%, which is a pretty huge for any global health technology. But I think it also shows, getting these things out there is really important, and a lot of children don't have access to them. But I think that the other reason that it made such a big impact was that infectious diseases are just very common there. So it's quite common for kids to have a bacterial infection at any given time. Um, there are other efforts as well where we do have a lot of on the ground efforts. So one is vaccination. That's often done through the World Health Organization and Gavi, this organization that purchases vaccines on behalf of poorer countries. And then there are some like on specific diseases like malaria and HIV, where there are dedicated efforts to scale up the distribution of medication. And those are often done again by nonprofits or NGOs. So we do have those. I think the problem is not just can we get these out on the ground, but how much of these technologies is actually being manufactured, and like what is the supply that we have of these technologies. And that's much harder because these are often produced by pharmaceutical companies that don't have an incentive to mass manufacture them, especially if they're being given out at cost price or less than that. Um, and so the thing that I'm quite interested in is trying to find ways to encourage that both the innovation, but also scaling up and mass manufacturing these technologies. So one idea that I've written about is advanced market commitments. They're an idea where you sort of commit in advance before something is invented, that when it's invented and if it meets certain standards, that you will pay for that product depending on how on the volume of that product that's developed. So they've been used for some vaccines, like the pneumococcal vaccines. So pneumococcal infections cause pneumonia, and one of the most common causes of pneumonia in Africa was this bacterial infection that we had vaccines against that, but they didn't target the strains that affected people in Africa. And so various countries and the Gates Foundation came together to develop this huge pool of funding to incentivize pharmaceutical companies to actually get their vaccines through trials, but also then manufacture them at scale. And they would be paid based on how many doses they produced and were administered in those countries. Um, and so I think things like that, where you're encouraging the manufacturing of the products, are probably a bit more important even than trying to distribute. We have good tools and capabilities of distributing a lot of these technologies right now, but we often just don't have the supply.
Um, so related to, so I want to ask some questions about how AI may influence health R&D progress, but before doing that, I want to quickly ask. You have many global health progress success stories, PEPFAR, and many others. Some of them implemented by aid agencies, some of them implemented by global organizations like vaccination drives, for example, and some of them by national health ministries. What I want to ask is, PEPFAR does seem to be the gold standard for what successful Western country aid policy or aid program could look like. Are there any programs that you think are quite underrated and should be studied or referred to more? I'd be particularly interested in hearing an example that was implemented by an EU country. But yeah, if you'd like to highlight
Hmm.
another success story by the US, that's also absolutely fine.
Um, I mean, I don't know the details of them, but I do know that sort of Gavi's vaccination program has been very effective. So, as I mentioned, Gavi purchases vaccines or supports purchasing vaccines for, I think they purchase actually about 90% of vaccines used in poorer countries, which is quite significant. And they help these vaccines get rolled out in those regions as well. And that's been effective at reducing child mortality from various diseases that are easily prevented through vaccination. So I think that's one big one. Um, what else? I think there's also been this program to provide what are called chemotherapy drugs for malaria, which makes it sound like they're cancer drugs, but they're really just sort of drugs that prevent or treat malaria symptoms one if the child is infected. Those have also been scaled up to like millions of children per year in those regions, and they're very effective. I think one of the difficulties that PEPFAR initially had that they managed to overcome quite quickly was actually just trying to develop the kind of network and the supply chain to get these technologies to where they were needed. They have this story that many of the people who led that talk about, which is that if you can get a Coca-Cola to a rural village, then surely you can get these medicines as well. And they tried to build these supply networks to actually get people to get technologies that were available in hospitals to the most remote places through local connections and networks. And so I think once you've built up those networks, they can then be used for various other areas as well, which is, I think, quite hopeful. Um, Trying to think of another, I mean, one sort of funny example, which is probably not very, or maybe it is cost effective, is how Europe tried to manage to reduce the prevalence of rabies. So rabies is almost always fatal if you get bitten by a rabies infected animal and develop symptoms of the disease. There's almost 100% chance that you're going to die in the next few days or weeks. And we obviously have a vaccine to that's taken after someone develops the symptoms or has been bitten that can prevent it from progressing. But rabies doesn't sort of spread between people very much. It's spread from infected dogs or wolves or other animals to us through their bites. And so it's mostly in those other animals which are called a reservoir species. And so they're the most effective thing to do is not to actually vaccinate humans. It's to vaccinate the animals. And doing that is quite difficult. You can't just, inject each of these wild animals. Um, and so what people did instead was they developed these oral bait vaccines. So put they would turn this vaccine formulation into a kind of oral dose that you could put into food or some other product that wild animals would feed on. And Europe had this program where they actually just dropped these oral bait vaccines from helicopters across forests to target, foxes and wild dogs, and reduce the prevalence of and spread of rabies to humans as well.
That's extremely interesting case study. By the way, I want to ask you about some AI related questions, but I also want to ask some actionable questions, like what next steps you would recommend to people who would like to do your line of work. But um, is it okay if we run over like 2 minutes?
Sure, yeah.
Fantastic. Then yeah, some quick questions
Mm. I think you've frozen for
about
me.
how AI will
Oh,
influence innovation. Um,
sorry. Could you repeat that? It was frozen on my
yes.
computer.
Is it now okay?
Yeah.
Can you hear me now? Okay, great. So yeah, you know about all the hype about AI, and many people do seem to be very optimistic about how AI may trigger innovation. So, in the context of global health R&D, what do you think about those predictions? And I know that this is a very important question that could be answered in a very long time, but yeah, I'm going to kindly request you to answer that quickly so that I can elicit some other information.
Sure. I mean, I'm both hopeful and unsure of I think it would be very helpful in certain areas and much less in others. So in terms of actually distributing a lot of these technologies, I think we actually do need kind of market shaping tools and incentives to drive that innovation. But in terms of the basic research, but also, collecting and analyzing data, I can see it being much more helpful there. And there are various examples like protein folding, but also kind of understanding interaction between different proteins, what different genetic elements do, and so on. So I think there's a lot of potential, but it's sort of you do often need these broader incentives, especially to work on the problems that are important in global health.
Okay, thank you very much. The other final object level question I want to ask is open science, related to open science. So again, our world in data seems to make it much easier for researchers to conduct various sorts of global health research by making data accessible. Would you say that even with the existence of our world in data, there is more room for open science-like movements or efforts within global health? Again, $1 million question that I'm going to kindly request you to answer rather.
Sure. I mean, we are usually using data that's publicly accessible already and making it much more easy to interpret and easy to explore than the existing data sets. So I think that's what our contribution is. But um, there's there's still a lot of scope for other researchers to make their data openly available. And I think there are various reasons for that. One is, people can build on that research. People can not just do their own. I think a lot of researchers are unwilling to share their data because they want to get credit for the work that they've collected or whatever. But I think there's a role for other people to collaborate through adding new information to the data or, helping with translations or finding small errors or trying to help with fixing or improving a data set. And I think that's something that we saw during COVID. So we had, hundreds of users from around the world contribute to our COVID data sets, add translations, correct missing information, and so on. And I think it's very easy to imagine yourself making a small typo or an error in your work that could be important. And I think that we kind of need to have this open source or open collaborative way of working to address that problem rather than trying to avoid it or pretend that it doesn't exist.
Um, Thank you very much for that. Now I'll ask two quick questions about yeah how basically what was an important intellectual influence that you'd cite in terms of like why you chose to work on this area and how you approach the problems within your focus area. It could be someone like a researcher, or it could be like a book or any other type of content.
So I'm not sure that I would point to, well, there are some. So one big one that has really just kind of changed my perspective is this book called How to Survive a Pandemic. It's about the HIV epidemic, mostly focusing on the effect in the US, and how scientists, activists, doctors came together to work on this huge problem and develop treatments for it. Obviously, like the first few years that the book describes are extremely depressing. And it takes a long time before you really see any progress being made there. But I think it really helped me to kind of appreciate how normal administrative processes or, political values or just petty personal problems can affect, some of these really important areas that we work on, and that it's not just science happening in the lab, but it's this whole context of what makes it easier, what the context is behind that, and what are the trends, what are the incentives to work on some problem and how it can be scaled up. So I think that was a big driver. The other was just sort of writing through the COVID years on various, trying to write about how the epidemic was progressing, the vaccines, and so on. That really shaped my view of how important it was to work on this area as a whole. That there was, I think, a lack of science communicators who could write about these topics for a general audience in a way that was easy to understand and clear, but also helped them to then interpret other data.
Okay. Thank you very much for that. And the final question is, let's say someone is extremely excited about the work you're doing at our World in Data, or just the general mission of our World in Data. What next steps would you recommend to these people? And let's assume that they're college students.
I would say work on things that you find interesting. Like often the thing that I do is, I find I look at like when was some technology developed and then when was it available or when was it discovered? And then what is the gap between those things and what actually happened in that gap? And I often try to find like interesting pieces out of that. But there are various things where you might just think, this is a question that I have, or this is a question that often comes up, and I just haven't seen a good answer to it. Or it's something that you feel is overlooked. And I would just suggest kind of digging into some of that, writing about that out of just your own personal curiosity, trying to understand that field, and then explaining it in a clear way to a wider audience. So I don't think that people are often quite scared of writing for a general audience. They might not have familiarity with that before, and I would just suggest sort of try to break things down, put things in a kind of step-by-step fashion, and just explain the progression of complexity. Like one thing that I like to do is kind of write things from a historical perspective. And obviously that makes it a bit more interesting, but I think the other reason to do it is because often the topics that I cover are very complicated. And if you explain them in the same sort of progression that scientists understood them, that makes it both engaging and easy for people to follow along. So those are things that I would recommend. Just write regularly, pick things that you're interested in, and then go from there.
Thank you very much for the conversation. This was really insightful and interesting. Dominic, is there any other things that we should do? Yep. Thank you very much, really.
No, this was
Oh,
great. Thank
thank
you so
you.
much. Both of you did a great job. Thank you.
Not at all. Yeah, no, it was really fun.
Yep. Take care. I'll
Bye.
Thank
probably
you.
send an email to you with more questions.
Sure.
Once again, nice to
Awesome.
meet you. Keishi, Dominic, see you guys. Bye bye.
See
Bye.
you.